Great, well, we'll get started. Welcome, everyone. Thank you so much for joining us this morning. We're still remote, and we'll get back to you about that, but this is the first, this is our first lecture of the combined MGH Brigham Women's Hospital Global Health Grand Rounds, also known as MGB Global Health Grand Rounds. I'm Joe Radigan. I'm here with Serena Koenig, Louise Ivers. We're the small group that helps arrange the speakers each month. Please contact us if you have any ideas about speakers or thoughts about topics we could cover in Global Health Grand Rounds. We're very eager to hear your suggestions and thoughts on this. We're excited today that Dr. Abebe Bekele from the University of Global Health Equity is able to join us. Dr. Bekele is the Deputy Vice Chancellor of Academic and Research Affairs and Dean of the School of Medicine at the University of Global Health Equity. He is a professor of surgery and a practicing general and thoracic surgeon. Previously, he has served as CEO of the Black Lion Teaching Hospital and the Dean of the School of Medicine at Addis Ababa University in Ethiopia. He has vast experience in surgical education, academic leadership and governance, and has served as a guest lecturer, international speaker, and external examiner in Ethiopia, throughout Africa, in Europe, and North America. Dr. Bekele is a member of the Governing Council and the Chairman on Examinations of Credentials Committee at the College of Surgeons of East, Central, and South Africa, otherwise known as COSACA. And he is editor-in-chief of the East and Central African Journal of Surgery. He has published more than 90 articles and book chapters, and is the recipient of several regional and international awards. He also serves as a member of the Advisory Council to the Ethiopian Ministry of Health and Sciences and Higher Education. Dr. Abebe's research interests include equity in global surgery, in trauma care and surgical oncology, and quality in healthcare. And we are delighted to have Dr. Abebe with us today. Thanks so much for being here.
Thank you very much, Dr. Ratigan and Dr. Ivers. It's a real pleasure and honor for me to join you today to talk to you about an institution probably you know the details of, but I'll try to kind of summarize where we are now since we got established in 2015. So thank you very much for inviting me today. I'll be talking about the University of Global Health Equity. This is a university that's established in Rwanda in 2015, the campus of which is found about 2.5 hours away from the capital city of Rwanda, Kigali, in a village called Butaro. When I say village, real village, in the middle of probably nowhere, surrounded by beautiful scenery of mountains, trees, but right across a hospital known as the Butaro District Hospital. This is a new university based in Rwanda with a grand vision of building the next generation of global health professionals. These include doctors, nurses, researchers, public health people, not only to be professionals, but also leaders and change makers. As you can imagine, particularly in Africa, there is significant shortage of medical schools. Number one, because the continent suffers from the highest global burden of diseases, but it also has the least number of healthcare providers. So in short, we have a few health professionals. UGHE wanted to contribute what it can to the global health workforce in Africa. And second, what can we do differently? Can we help to produce professionals who actually fulfill what we mean by competency-based education? Doctors, nurses who are medical experts, professionals, communicators, and you name it, to handle today's and tomorrow's problems. So these are the two main reasons UGHE was set up in Rwanda. It has its own vision. It has its own mission to contribute quality professionals, leaders and professionals in Africa, in the world. UGHE is owned by Partners in Health. Partners in Health entered Rwanda in 2003. Within 10 years since they entered Rwanda, 3 hospitals were built in Rinkwavu, Kirehe, and in Butaro. The last hospital built was in Butaro in 2012. Right after the hospital was inaugurated, in partnership with Harvard, the first certificate program in global health delivery was conducted at UGHE. And this was the very first academic experience for PIH in Rwanda. And that sparked the creation of the bigger version of UGHE. And in partnership with our partners, donors, in 2015, we established the Bill and Joyce Cummings Institute of Global Health, where the master's degree program in global health delivery is now housed. In 2016, the campus expansion was started, the campus construction was started. In 2017, the first cohort of MGHD graduated, about 22 students. The same year, we established the second academic unit, which is the Center of Executive Education. 2018, I joined as founding dean of the School of Medicine, and the School of Medicine was officially opened in 2019. The same year, we also inaugurated the campus. Since then, several academic units have been established. The EDQC, the Center for One Health, the Center for Nursing and Midwifery, the Center for Gender Equity, the Center for Institute of Global Health Equity Research, our Innovations Unit, and most recently, our Center for Equity in Global Surgery. This is a young, expanding university. So next year, the year after, more academic units hopefully will be coming. So the UGHE founder, the strategist, and then the chancellor until he passed away, unfortunately, this February, and it's led by its board. The board sits under the PIH board. 51% of the board members are from PIH, the rest are from Africa, and partners and supporters of UGHE. These are the founding partners in 2014-15. I wanted to draw your attention to the government of Rwanda and its sector institutions. UGHE is probably a good example that if local stakeholders and the government has a stake on projects in the world, things will really be successful. The support and partnership we receive from the government and the Ministries of Education, Health is enormous. And in partnership with our Boston partners, UGHE was established in 2015. However, we work with several academic partners at the moment, several, most of them in Boston and across the US, in Africa, in Europe, academic resources institutions, digital learning institutions, NGOs, surgical and other colleges, and others. Our faculty come from all across the world, from Canada, the US, Europe, Africa, India, and Australia. So does our students. I'll say a few words about that in a while. Like any academic institution, UGHE has 3 main activities, domains. These are teaching and learning, research, and community engagement. At the moment, we have 11 academic units. I'll say a few words about some of them. The very first institution we set up is our Institute of Global Health, which at the moment houses the MGHD program. The MGHD program is modeled after a similar program at Harvard Medical School, and it's the flagship program at UGHE. The intention of setting up this program is to produce health professionals with ability to problem solve, leadership and management, and research. This program at the moment is run by faculty from across the US and the world. It's a 1-year blended program, 5 months virtually and 7 months in-person residential. And at the moment, there are 3 tracks under this program: the One Health program, the health management, and gender and sexual reproductive health. These are the ones we have already established. Hopefully next year, 2 more will be added in global surgery and community health. So hopefully by 2023, the MGHT program will have 5 tracks. And it's a very good, successful program. At the moment, so far we have received trainees from about 27 countries. And this year we have recruited the 8th cohort from about 19 countries. And this is the data which is about 4 months old. So our students come from all across the world, as you can see from this map. And we hope this diversity will continue in the future. This year, we recruited 55 students, 25 for the sexual reproductive health program, 15 for the One Health, and 15 for the health management track. And our graduates have been successful so far. We have 182 alumni, including this year's cohort, several publications, almost all of them are employed, significant have enjoyed a salary increase. Many have pursued PhDs and several global engagements across the world. This institute also houses the Innovation Center. The Innovation Center is set up to encourage UGHE students to be involved in the world of innovation, collaboration, and then dissemination. We started with just a few UGHE students. We're now working with several health and other students from Rwanda, from 4 other universities in Rwanda. And we recently reached out an agreement with the Stanford, the Biodesign Center, to expand the fellowship program and establish a bio innovations lab. Our students are working on a few innovation projects, and hopefully this will be an initiative that can be an area of partnership between us, Brigham, and MAS. The second academic unit we have is what we call the Center for One Health. One Health, as you know, is an integration of human health, animal health, and environmental health. And under this center, several research projects, the One Health field course, the MGHT track in One Health, and several other community engagement activities are going on. And one thing that makes our School of Medicine unique is that we are the only university in Africa that has integrated One Health to the medical school curriculum. And the publication will come out soon that details about how we did that and why we did that. The third is our Institute of Global Health Equity Research, established in 2020 with its own vision and mission, clearly aligned to the needs of global health in the world and the vision and mission of UGHE. At the moment, the focus is on establishing Rwanda's first clinical trials unit. We have recruited a few faculty, trained them on clinical trials, and discussions are happening with several partners on how to go about this. Also to establish Rwanda's first biobank and genomics center in Africa. About 10 minutes away from the UGHE campus in Butaro, we have the Butaro District Hospital, which is the only cancer treatment center in Rwanda. And that's a center where significant amount of cancer research goes on. So based on what is already done by PIH in this hospital and by its partners at this hospital, we hope to expand the research and dissemination work by establishing Africa's cancer research hub. So these 3 are new initiatives being considered under the Institute. However, several clinical, basic medical sciences, NCD research activities are going on there. We've also been successful in our grant applications and development of partnerships. So far, we have a success rate of about 35% of our grant applications. About 57% are still pending. Our rejection rate is about 7%. And we have tried to raise some research grant to sustain the institute and foster the culture of research in the institute. We've also been successful in publishing. Data from last year shows about 55 publications. Original publications have been made at UGHE. several editorials and op-eds, and a few book chapters are done by faculty and students at UGHE. The fifth academic unit we have is the center that houses our short course programs, what we call the Center for Executive Education. This is the center where short courses designed for global health professionals, leaders from ministries of education, ministries of health are done at UGHE. We have several partners who work with us in delivering these, and we follow several formats when we deliver this. It might be a 1 year long in-person or digital version, or a one-time, 1 week or 2 weeks, or a blended program, virtual, in-person, virtual, and in-person. Our flagship executive education program is what we call the Global Health Leadership Program. And in the future, we hope to launch programs in nursing of leadership, SRH leadership, higher education leadership program, and executive education program in health financing and leadership. I'm very sure Dr. Ratigan and other faculty at UGHE will recognize some of the names here, because you are the ones we are working with in development of these programs. The sixth is our Godley-St. Goar Department of Community Health. This is the department that is responsible for introducing community-based education to all our students, the second flagship program we have at UGHE. Our medical students spend close to 17 to 18 weeks in the community, and our MGH students spend a month in the community. We have designed a program called community-based education to introduce them to community-based healthcare and community healthcare workers. This center is also involved in participatory research, service, and development of the community. Several activities are going on, have been going on. Because of COVID, the department slowed down for about 2 years, but activities are resuming as we speak. Most recently, the CBE, the department developed what we call the CBE Global Program. This is a program that hopes to recruit students from the US and Europe for 1 month to come to UGHE, spend 28 days with us, and undergo a prescribed curriculum-based, community-based education. And we hope this will be an opportunity for candidates outside of Rwanda to get better exposure in global health. And hopefully, not only will it benefit the students, we also hope to raise some funding to sustain this department. The first cohort of 20 students will be recruited next January. The seventh is our Center for Gender Equity. This is the center that takes care of the gender and SRH MGHD program, currently staffed by 4 senior faculty and a few junior faculty. The 6 months of the undergraduate medical curriculum is about social justice and equity. So this center is responsible to administer the gender equity and social justice module. A mentorship program was launched by this center a few years ago, quite successful, for global health leaders across the world on voluntary basis. We recruit about 25 mentees and 25 global mentors, and we serve as the platform to connect them. And there are also several research projects and other activities in this center. The eighth is our Center for Nursing and Midwifery. Last year, this center launched the Executive Education Program, Leadership Program in Nursing and Midwifery. From about 200 applicants, we recruited only 20. This year was even worse. Our acceptance rate was about 6%, and the first cohort is doing their program at the moment. And this center is also working on a nursing oncology master's degree program and a perioperative nursing program. The ninth is the centerpiece of quality assurance at UGHE. This is what we call Educational Development and Quality Center. This center is responsible for a series of faculty development programs. We have had several of these in partnership with Brigham, Harvard Medical School, This is the center that takes care of innovative student assessment. All UGHE programs are evaluated at the end of each module and at the end of each year. We've introduced several innovative teaching techniques such as flipped classrooms, team-based learning, problem-based learning, and we are trying to shy away from traditional lectures. There are several educational research projects in this center, and our simulation center is housed under the EDQC. Hopefully, we will launch a master's and a certificate degree program in health professions education, again in partnership with colleagues from Boston. Dr. Rattigan is one important component of, and his colleagues are components of this program. The 10th is our Center for Global Surgery, established this year in February, to foster the fight in global surgery and anesthesia care. The 6 pillars under this institute are fellowships in global surgery. We now have 5 fellows in partnership with PGSSC at Harvard. Research and innovation, but there are about 13 research projects going on. And hopefully this center will take care of the MGHD track in global surgery next June. We hope to be the center for policy and advocacy discussions in Africa as far as global surgery is concerned. And we also hope to host global surgery conferences every 2 years in Rwanda under this center. The PGSSC is an important component, founding component of this center. The last is our School of Medicine. The School of Medicine at the moment houses 3 academic programs. The first one is the MD and MPH program, what we call the MBBS MGHD program, 6.5 years, 6 years for the medical school and 6 months for the master's program. The second is our specialist in blood banking program together with Rush University. And we hope to launch a PhD program in medical sciences and health equity, particularly 4 tracks: cancer biology, cardiovascular medicine, ID, and neurosciences. So these are the 3 programs under the School of Medicine. The School of Medicine, as I said, was inaugurated in 2019 with 30 students from Rwanda. Cohort 2, again, 36 students from Rwanda. This year we recruited cohort 3, and we recruited additional students from Burundi, Tanzania, and Uganda. And hopefully next year, recruitment will also include the PIH Africa countries, Sierra Leone, Malawi, Liberia, and Lesotho. And by policy, we recruit 70% women, 2-to-1 ratio of female to male. It's by policy. We believe the School of Medicine follows a unique approach in teaching. The curriculum is competency-based. It's completely integrated vertically and horizontally. The way we try to teach is using innovative techniques, flipped classes, TBL, CBCL, and a bit of interactive lectures. Even from basic medical sciences, the basic medical sciences teaching is integrated to the lab and simulation. I need to mention the contribution of Dr. Peter Weinstock here, who has been really instrumental in training our faculty, supporting our curriculum development, and coming to Rwanda, I think 3 times so far, to do student training, faculty training, and so on. From day 1, our medical students visit the hospital as basic medical sciences students, hands-on in the community. And our curriculum is emergency care focused, because 90% of what African doctors are expected to do after graduation is emergency care. So our curriculum is targeted towards emergency care. We work a lot with partners, and this is how we maintain the quality of education at UGHE. Between January and now, we have received more than 40 visiting faculty for a duration of a week, 2 weeks, 3 weeks, mainly from Boston, to teach in general surgery, internal medicine, OBGYN, pediatrics. And this has been such a support, huge support for UGHE. Our students are heavily engaged in research. About 6 of them are published already. 2 have presented in international venues. A couple are traveling to Australia next month and to Namibia to present the research article. They're just year 3 students. And we have set up a Big Brother, Big Sister mentorship program and faculty mentorship program for them. The dual degree program in the One Health focus is also what we focus on. I'm also really glad to announce that we received the Aspire to Excellence Award 2 weeks ago from the Association of Medical Educators, the AME Europe, which is quite a milestone for a young medical school in Rwanda. I think we are the only medical school in Africa to receive such a recognition. And it's mainly because of, not only because of us, but because of the partners we are working with. And as you can imagine, establishing such a medical school is quite expensive. It's really expensive. And asking poor African young boys and girls to pay for tuition is systematically selecting those who can only pay, which is against our principle. So the decision made by the leadership, the board, is tuition waiver, scholarship for all medical students. In return, they sign commitment to serve in the public setting for 6 years with their own government. So in a way, they are paying it forward to their own people, to their own government. And these are our teaching sites. North of Rwanda is where Butaro is located, the Butaro District Hospital, which 2 weeks ago was upgraded to a level 2 teaching hospital. I'm really glad to announce that. And the 2 other PIH-run supported hospitals in Rinkwabu and Kirehe, to the east of the country. We were sure the students will also spend some time in Kigali to do a bit of advanced teaching. And hopefully for their electives, some of the students will travel abroad, get better exposure of what medicine looks like in the rest of the world. The campus was inaugurated in 2019, January 25th. When I say in the middle of nowhere, this is what I meant by in the middle of nowhere. It's really in the rural part of Rwanda, surrounded by beautiful mountains, a volcano, and trees. We have quite a setup for rural-based medical education teaching, but quite equipped and quite conducive for research and learning. We recently expanded it. The second phase was completed a few months ago. The plan is to establish a university with a capacity of accommodating 1,000 students and faculty. Several classrooms, several lab spaces, faculty office, recreation space, meeting space, and student services. And this is a huge, almost 100,000 square feet of land that was generously given to us by the government of Rwanda. And hopefully this will be the university in a short period of time. Hopefully, we hope to establish at UGHE. And in memory of our founder, Paul Farmer, we hope to set up the Tropical Forest Glade. Those of you who have been to UGH, the campus, know the entrance. So this will be on the right side of the entrance. Joe, I'm sure you recognize this space. And this hopefully will be Paul's tropical glade. We also have a small piece of land in Kigali, near the new Kigali Health Village, near the cardiac hospital, the IRCAD Center, the Masaka Hospital, where we hope to establish our research institute. A relatively smaller piece of land, but we hope our research institute will be placed there. And as I said, the Butaro Hospital was recently accredited, promoted to a teaching hospital. Serious work is now being done to double its capacity. Theater, accommodation, admission, imaging, to double its capacity. And hopefully this will be the look of the Butaro Hospital next year in December. So in conclusion, looking forward, We hope to establish our PhD program in basic medical science and health equity soon. This is our way of sustainability, training our own young faculty, and in a way, sustaining science and discovery in Africa and Rwanda. We hope the MGHD options in global surgery and community health will start, and the other MGHD programs will also be strengthened. In a way, I'm extending our call, our invitation to all of us here to partner with us in teaching, master's students, doing a module, a course with us, partnering with us in supporting students in their research, in their practicum. Several master's programs in nursing, oncology, leadership. The team is already working with a team from Harvard and Brigham in the Masters in Health Professions Education, and the BSc program in Supply Chain Management, and other academic programs. The medical school in particular would benefit from a lot from partnership with both institutions, Brigham and Mass, particularly in teaching basic medical sciences, integrating clinical medicine to basic medical sciences, in simulation teaching, and in the teaching of internal medicine, surgery, ENT, radiology, you name it. Partnerships can be one lecture online. It can be a one-week visit in the campus. It can be a one-week fellowship with us. Or if I'm pushing it too much, it might be a one-year sabbatical. Any such support will definitely help us maintain the quality we have introduced to the region in the continent. So in conclusion, at the moment, we are a small university, a global university in Rwanda. Hopefully, maybe in our lifetime, a real global UGHE. Thank you very much, everyone. And thank you very much, Dr. Ivers, Dr. Rattigan, for inviting me today.
Wow, congrats. That was fantastic. Thank you so much for taking the time to speak with us. And I feel so inspired by the ambition and the scope and the focus on equity and partnerships that you're describing. And I'm certainly hopeful that as our conversations have been going, that we'll be adding Mass General Hospital to the list of partners. I want to invite our attendees to submit any questions that you have. We'll be happy to pose them on your behalf. And maybe to get us started, I want to ask you two things to comment on. I know that in your founding, the idea of One Health was really important, and you mentioned this in one of your slides. And I think increasingly, as we think about pandemic prevention and preventing spillover events of infectious diseases and outbreaks, I'd love you to expand a little bit more on your One Health philosophy. And then the other thing that I think is so interesting and important is you talked about Butaro Hospital and caring for patients with cancer. Yesterday, President Biden came to Boston to talk about a moonshot about cancer and preventing cancer deaths. He was focused on the United States, but I wonder if you could also share a little bit with us about your ambitions around cancer detection treatment. And then after that, I'll pose some questions from the audience. Thanks.
Thank you, Dr. Ivers. One Health, as you nicely mentioned, is an approach to health. COVID is a typical example. Had it not been for the interplay of the environment, animals, and humans, we wouldn't have suffered like this because of COVID. And Africa has quite a number of diseases where all three are highly, highly interrelated. So we have made a bold decision of integrating One Health into the curriculum, both basic medical sciences and the clinical medicine. In basic medical sciences, the One Health faculty, the basic medical sciences faculty, and the clinicians take the student to the hospital, or they sit in a classroom and discuss about the diseases from all aspects. That has been going on for 2 years now. Many of the students have written papers about it, are engaged in research. And recently, we are finalizing a few case studies. And the way we take history at UGH, medical students take history to include a One Health history, Physical examination designed to extract One Health-related findings, investigations in treatment, prevention, community work, involving the environment and humans is what we are trying to introduce. There is a team working very closely with us from the One Health Center in the School of Medicine, and the first publication will come out soon. That is what we are trying to do. Your second question is about cancers in Africa. As I mentioned earlier, the Butaro Hospital is the only cancer center in Rwanda. Recently, the Rwanda Military Hospital has started radiotherapy services, but Butaro remains the main center, not only for Rwanda, but for Burundi, some part of Uganda, and some part of Congo. Patients come to Butaro to get the service. Unfortunately, cancer care has several components: diagnosis, surgery, chemo, radiation, prevention, and post-care. The service is really good at the moment, but it's not where we want it to be. So some expansion to accommodate more patients, more chemotherapy, CT scan, MRI, maybe a PET scan, good surgical services need to be part of the work. And unfortunately, the region suffers from specific prevalence of cancers. The esophageal cancer belt cuts across Rwanda. Iran, Iraq, Sudan, Ethiopia, Kenya, Rwanda, down to South Africa. Some types of lymphoma are unique to Rwanda, Uganda, Burundi. And the usual suspects, cervical cancer, breast cancer, are very common, provided the work done by Rwanda in eliminating cervical cancer is huge. Given the early diagnosis in breast cancer, the move towards self-breast examination, imaging, there is huge research need. Understand why this is happening. By profession, I am a chest surgeon. I deal with the esophagus, the stomach, and mediastinum. It's very unusual in the rest of the world to see a 25-year-old with a squamous cell carcinoma of the esophagus. But it's common in Africa, real common. Breast cancers are diseases of the very young, 25 to 40. And I'm yet to see a stage 1 breast cancer. I've been in practice for about 18 years now as a surgeon, but I've never seen a stage 1 breast cancer. So not only is diagnosis, treatment is needed, we need to understand what's going on. That is why the Cancer Research Hub idea, the genomics idea is important, crucial for Rwanda as a country and for the continent as Africa. That's what we're trying to build at the moment. The PhD program in basic medical sciences I mentioned earlier ties neatly with this concept. If we train the professionals, the experts in basic science research, integrate them to the new African Cancer Hub or the Genomics Bank, things might change eventually. 5, 10 years from now, we'll understand what we are dealing with better.
Thanks.
Dean Bekele, can I thank you so much. That was an amazing, it was a great overview of a really exciting and inspiring project and school. One thing you talked about was UGHE as a rural medical school, some situated 2 hours outside of the capital. Part of the road to get there is unpaved. Can you talk about the reason UGHE the team decided to put UGHE in a rural area? What's the goal of that? And I realize it must be very difficult to recruit and train faculty and retain faculty to work in a rural area. Can you talk about some of your strategies and how you've been able to attract a dedicated group of faculty?
Yes, thank you, Joe. I think that's a great question. You're right. The campus is in the middle of nowhere, in the middle of a deep rural part of Rwanda. And we always get this question, why? And our simple answer has been, why not? Because that region, that piece of land deserves quality care, quality education, as a simplistic version of it. However, number one, the era where patients come to the hospital is probably going away. We need to train students or medical practitioners that go to the community. Because so far, this did not work out well. For one reason or the other, we have been producing professionals that do not understand the community, that do not understand who they are dealing with. So one of the main reasons is that what if we train our doctors, nurses, practitioners inside the community, inside the rural part of Rwanda, and design a program called social medicine, community-based education. Not only will they have access to the hospitals to see patients, they will also see the patients inside the community. That's number one. Number two, the patterns of diseases you see in the capital cities and in the community are very different, because the basic barrier is access to care. You only find those who have access to care in Kigali or in Addis Ababa. What if our students are inside the community where the patients actually are? You bring access to the patients rather than the other way around. And third, let's go back 300 plus years and look at Boston. Harvard was just one building. Fast forward 400 years. And that's, I strongly believe the founders of Harvard had that in mind. I think this is what founders like Paul, Ophelia, Joya, Dr. Agnes had in mind. Let's sow the seed now. 100 years from now, that might be the academic center, the treatment center for the region, the research center for the region. So I think these are why the founders decided UGHE should be there. And one of the reasons we won the Aspire Award this year is for a concept known as place-based education. Place matters when you train quality medical students, quality professionals. And the place is inside the community. Thanks, Joe, for the question.
That was great. And I think we have a comment or question from Dr. Mukherjee. Thanks, Drea, for this one. Because I've been thinking about this too. Equity is in the name of the university. You talked a bit about the placement and the training, the teaching. Can you share a little more with us about how you teach equity? How is equity taught to students? Well, by experience, by example is the short answer. In the campus, to begin with, faculty, students, everyone dines together, shares the same office, the same library space, same bus. We do not look at ability to pay, who you are, what you are, when we recruit masters and medical students. That is the last of the recruitment criteria. What we say is the young people with the heart, the brain in the hands to practice medicine should be given the opportunity to do so. The fact that they can't pay is will not be a reason to reject them. Second is our students spend significant amount of time in the community. They follow patients from the hospital to the community, spend time with them. The last Saturday of every month is Umuganda in Rwanda. That's a day of community service. A foreigner student, a Rwandan student, faculty students get involved together. At the end of the day, it's all about role modeling, and faculty like Paul, Joe, Joya, several others who are known for their work in equity come to the campus, like, simply spend significant amount of time with them, have dinner with them, have chat with them, we take them to the community, the hospital, and that's where they learn it from. Global champions like Vice Chancellor, Dr. Agnes Binagwaho, they see her day in, day out. So by modeling, by example, they see
what their teachers, mentors are doing. That's what we try to do.
To follow up on that, because I think it's related, is the role of social medicine, the concept of social medicine. And, you know, I've seen social medicine in the US here both expand in my time living in the US, but also be kind of under attack. And you see op-eds and opinion pieces talking about, oh, we're teaching students to be woke and we're not actually teaching them, you know, the science. And so, of course, I don't agree with that opinion, but how do you, I mean, perhaps you feel like you've answered this, but I think it's such an important component of medical education. In addition to that example and leading by example in the equity and the placements of students, what are the other approaches that you have to social medicine, and how do you push forward as such an inspiring leader as you are to having any skeptics understand the role of social medicine in your educational platform?
Yeah. I must admit it's not an easy question, Dr. Ivers. Fortunately, such a tense environment is not yet there in Africa, in Rwanda, but I understand where your comment is coming from. But well, I think the question is, do we have students and faculty who believe in this, who believe in equity? Starting from faculty selection, faculty recruitment. If you have the number and quality of faculty who really believe in what you're doing, the distance 2.5 hours away from Kigali doesn't matter. In the School of Medicine, the past 4 years, no faculty has resigned or quit. No one has complained about the distance, the separation from family. And no student has said, I'm done with this. So I think it first starts with selection of people who believe in the idea. Second, to keep the momentum going. The dialogue, the discussion, the publications, the research, and showing them evidence that this is what we want to do. This is something in our blood. And so far, there has not been a better example than people like Joya, like Dr. Agnes, like Paul, like Joe. When you constantly talk to students about that, it kind of is ingrained in their mind. They strongly believe in it. And we try not to do things that distract them from such a belief, such a thinking. Many of them write op-eds, publish papers, do interviews, attend webinars. Next year, we hope to launch the global health equity discourse. This used to be a seminar we used to do every Thursday afternoon, once a month. Because of COVID, it was discontinued. We hope to relaunch that again. And I think that the most important thing is to keep the dialogue going and work with people who support the vision.
Thanks, Joe.
Yeah, if I could also add one word, I read a question, Tom Randall, how can I support your work? Thank you very much for the offer, Dr. Randall. Our ambassadors at Brigham is Dr. Rattigan, and at Mass is Dr. Ivers. Please reach out to them whenever you can. And please feel free to reach out to me at any time, and we'll be very happy to accept the offer. Thank you very much for the offer.
And Dean Bekele, one last question. The Masters of Global Health Delivery that all the medical students get. Can you talk a little bit about what skills that gives them and how you see that fitting into their professional development?
Yes. This is modeled after a similar program at Harvard, the medical school, the MGH program. The plan is to prepare young medical doctors and hopefully nurses after a few years, who understand what global health equity means. The historical background to colonial medicine, to social medicine, to the social determinants of disease and health, to African history, African medical history, socioeconomics. Then who understand, who can do research and understand research. Professionals who understand policy, who can contribute to policy, and who can support ministries, governments in policy design and implementation. And professionals who are good in leadership. We hope not only to produce professionals, just doctors, but doctors who can lead medical hospitals, district health centers, research institutes, people who can replace me eventually, or people like all of us who understand leadership. People who understand what management of pandemics mean, preparation for pandemics, management of pandemics mean, who understand health systems, the 4 S's of health systems, who understand those. So hopefully by the end of the 6.5 years, not only we will have just doctors, but who understand these competencies.
Okay, I know that Dr. Rajgan said that was the last question, but we still have a few minutes left, and there's a couple of great ones have just come in the last few minutes. So I want to make sure, and maybe we'll get you riled up. So one question is about your focus, your policy on the gender balance, and a question about whether you got any pushback about focusing your enrollment on women and thinking about how important women are in delivering care globally. The second question is about how you're thinking through, the current model which you're using of bringing folks from the global north to Rwanda as part of your teaching partnerships, and how you envision that in the future kind of upending the historical role of colonial medicine and the dynamics of global north, global south interactions. So 2 questions kind of also about equity, and you're thinking about those. Thanks. That's the last kind of combined question.
Thank you, Louise. Well, there is data out there in Africa, in Rwanda, all over the world. The number of doctors, women doctors, as compared to men is very low. Go to specialty, it goes down significantly. Subspecialty, it's below 10%. Researchers, biomedical scientists, it even goes down significantly. In my opinion, I guess the UGH leadership share this with me, the solution is not publishing more about this. It's taking steps about it. The step we have decided to take is recruit more women. And it has been such a great decision. The women students we have at UGHE are unbelievable, are amazing. These are the ones who score 4-point grade average, who write fantastic research papers. So based on the available data, we decided to take actions. We said we will recruit more students, more female students in the medical school, and preferably also in the MGHT program. The medical school is by policy, 70%. There was pushback. There was pushback from the regulatory bodies, from the medical councils, and from people who work with us. But I guess the reason we create policies is to have a defense. So look, we've created a policy. We don't want to change it. So that's, I guess, one way of protecting ourselves. But this is a policy decision. The second is experts from the US. See, the kind of partnership we developed is partnerships from the very beginning. It's not like one faculty from Brigham will fly on Monday and teach whatever he or she wants. It's not like that. During the curriculum development phase, we worked with several partners in the US. We know what's happening January 10 next year. What kind of lectures are happening, what kind of bedsides are being given, what exams are being given. So if there is a visiting faculty from among this group now, I'm going to link you with, let's say if it's an internist, the internal medicine department chair. Long process of preparation. What are you going to do when you arrive on Monday? What lectures are you giving? What bedside are you giving? Would there be exam that week? How will you be involved? So it's a completely integrated visiting faculty program. We are against helicopter research and teaching, that somebody comes in, does a certain lecture or research and goes back. We are completely against that. The second benefit is we always link you with junior faculty and our local faculty so that there is exchange of expertise. There is learning from one another. That is why we need strongly depend on the partnerships. Correct me if I'm wrong, Joe, but I think we already did 2 faculty development programs with Brigham. This is based on our request. Our faculty identified this topics. We designed the program together with Joe and the team. We co-delivered it. I served as a teacher. Joe did some teaching, other colleagues, based on our request. It is never based on the partners, shall we say, wish. That is the basic change we have introduced. MGHD faculty, we know what's happening in January, February, March, April. So even when you decide to visit us on this particular day, even before you fix the date, we will have that discussion. Could you please come on this day, deliver this course? So that kind of discussion takes place. And that pushes back the, shall we say, the neo-colonial thinking. I don't like to use that word. I prefer global health equity, but that pushes back that thinking. I hope I have tried to address the question.
Yeah, thanks very much, Dean. I'm sure we could spend a whole hour talking about that question, and I'm sure that the person posed it would love if we did. So I'm sorry that it came towards the end, but it's a really important conversation as well to have. We've come to the end of the time. It's been absolutely fantastic having you. Thanks for taking the time to speak with us, and thanks to all of our attendees. And look out for our next speaker for next month in your inbox. Thanks, everybody, very much.
Thank you very much. Thank you very much.